Good morning, everybody, and welcome to Grand Rounds. I wanted to just make a couple of statements about the current situation with respect to the COVID pandemic and vaccination by way of then introducing our Grand Rounds topic and speaker. So as I think people know from the news, the rate of infection has been ascending for the past number of weeks and continues to do that incrementally. We're at a rate in New York City and in our hospital system, which is still considerably below, the worst, which was in the spring, but it's continues to increase incrementally, and the peak is not reached yet, but is estimated to be maybe 4 or 6 weeks away. At the same time, you also have the concern about the new strains that appear to be occurring, and that they may be more contagious, even if they're not more virulent. And so it's not clear how that's going to impact the infection rate. So overall, there's larger numbers of people getting infected, coming into the emergency room or coming into the hospital, but the level of severity is diminished in terms of how many people end up in the ICU intubated or die. And I think that's because we've learned how to take care of people better, and there are some treatments. At the same time, also, the vaccines are now being administered. It's very much of a fluid situation in terms of who the groups that are eligible and how much supply is available and where to get it. I'm not going to go into the specifics. You've probably received from Lou Baptiste and Ellen Atia emails that are explaining this, but the admonition is get it wherever you can. But if you don't have if you're not able to identify a site and a source, you should immediately call Evelyn or Alicia Corneau, our infection control nurse, or Lou Baptiste's office, and between the OMH, NISP, and the NYP Columbia mechanisms, we'll direct you as best we can. And the last thing I'll say about that is that I know there's some reticence on the part of some people about whether it's safe or so forth. There's no question everyone should get vaccinated, everyone. There's nothing to worry about with respect to that. So I encourage everybody to get vaccinated. Next week, our Grand Rounds is going to be on the Healing Communities study, a data-driven community-based approach to reduce overdose deaths in highly impacted community, and that'll be presented by Nabila El-Bassel, who's in the School of Social Work at Columbia University. I think you may know that Nabila, in collaboration with two of our faculty, Fran Levin, Ned Nunez, and others, received a very large grant to develop a community-based approach to the opioid epidemic. And Nabila will present that next week. But today, I'm really glad that we could have Dr. David Henderson join us to speak. David is a Bostonian. He's been there for most of his career. And we were just sort of comparing notes about how careers evolve over time. And in David's case, he started out after his education, which was at Tufts for his bachelor's degree and then his medical degree at the University of Massachusetts. He then did his postgraduate training in psychiatry at the Massachusetts General Hospital and Harvard Medical School, where he worked closely with one of our colleagues, Don Goff, who's the other half, I won't say better half, of Lisa Dixon, and trained in the psychopharmacologic treatment of schizophrenia, and then continued on faculty at Harvard and in Boston until he was asked to take the chair and take the chair of psychiatry at Boston University, where he's been since 2015 and is also in the position of assistant dean for diversity and inclusion. So David and I were joking beforehand that you start out as a very ambitious and focused researcher in a particular scientific area. In his case, similar to me, we were very much oriented to clinical psychopharmacology and developing novel forms of pharmacologic treatment for schizophrenia to improve efficacy and safety. But as his career has evolved, he's been drawn in a way that reflects his humanity and generativity into other aspects of mental health care, including the training of individuals in mental health care in underdeveloped, less developed countries, addressing issues concerning the social determinants of health, and also in the implementation science of how to get evidence-based treatments disseminated and used more broadly. So it's a pleasure to have David here today, and reflecting what I just said about how as you ascend in your career, you get drawn into more important and socially relevant causes to address us today on health, equity, and justice for people with mental illness. So David, thank you for coming, and we look forward to hearing what you have to say.
Great, thank you very much, Jeff. I'm just going to share my screen to get started. Okay, can everybody see that okay?
Yep.
Okay, great. So it's really a pleasure to be here. I am very fond of your institution, and there's a lot of great people that are currently in the institution, but also that were there in the past, and particularly and many people who have dealt with some of the things that I'll be talking about. This is my disclosure currently. So I'm going to talk about really, a different aspect of mental health outcomes. And as Jeff pointed out, I started out in clinical trials in schizophrenia, and still do that. But over time, and certainly as I moved to BU and to work at Boston Medical Center, which is a safety net hospital, my views started to change a bit, and I think I expanded my horizons and so on. And even when I was heavily into clinical trials, I always thought, like, we're missing something, because we randomize a patient, they get a drug or placebo or whatever, they come in, they do these assessment scales. But the assessment scales do not really capture their life and what's going on in their life, and even more so, what's going on in the country. And so how they respond to our assessment scales is also, it's not just only influenced by whether they got the drug or not, but it's also influenced by what's going on in their life, in the country, the world, their communities, and that sort of stuff. And in fact, those things may have a bigger impact on what they're presenting at any one time. And so I've often had that thought, and there's been some evidence in looking at, large scale trials in other medical disciplines where they took into account kind of the environmental effects or events, and showed that it changed the outcome if you take those into effect. So at any rate, I'm going to talk a little bit about some of the experiences that we've had at Boston Medical Center and working in Boston. And I recognize that in New York, you guys have led the way in many ways in kind of mental health reform, and expansion of services and capacity and so on. But we still have a long way to go in this country. And as I said, I spent many years looking at the mortality and the SMI population, and I focused quite a bit on the impact of the antipsychotic drugs, and then some of the lifestyle choices and so on. And everybody has seen this slide before. It's a classic slide, but again, I think there's factors that are missing that impact the mortality, and as Jeff mentioned, those social determinants of health, as well as, and we'll talk about the criminal justice system and how it may actually impact individuals and so on. And even more so, we look at, the modifiable health risks, and then there's things about, access and utilization of medical care. Now we have focused a lot on access to improve access. Um, but I do not think that we've done a great job on the utilization of care, and meaning that patients engagement. And I'm going to show you some data and talk about some of our programs that really, if you look at them in a vacuum, you say, oh wow, that's tremendous progress. But if you take it all together in the context of other systems, you realize, oh wow, there's actually something wrong here. So we're going to get to that. And of course, I have to acknowledge, what has been going on these past few years in this country, and even more so, with it first, highlighted, of course, with um, although it's been going on for decades or centuries, but the inappropriate killing of Black people by police and so on. So we've all have seen this over and over again, but we can't really ignore this, and certainly even recent events highlight why this is such a big concern, but it also, this impacts people's lives, and this impacts our patients' lives as well. And we have to think about it. And then the notion that, there's all types of racism, um, from overt to covert, that people experience, and that have a negative impact on people's health and their outcomes. And so we really have to, be mindful. Again, it's just not the pill, but people have lives, and with potentially negative experiences happening all the time, which can impact on their health outcomes. And of course, we've seen protests from around the country, but we've seen a striking difference in how the protests have been handled. With the top picture, with a protest in Michigan about opening the economy. And then when there was a protest about racial justice, the response was actually quite different. And of course, we just saw this play out once again in Washington, D.C. Last week. I'm sure everybody was horrified, scared, and a whole bunch of emotions. But it's pretty remarkable how the disengagement, excuse me, what was handled. And you could easily say, well, if this was a Black Lives Matters protest, we suspect that it would have been handled quite differently. Just extremely unusual. Excuse me. So, but again, but this is just a reminder that there are a lot of things going on, but also many of our patients, particularly patients of color, may experience our health systems very differently than what we think we are, or who we think we are, and that sort of stuff, and they may engage the healthcare system very differently. And of course, that there's been several highly publicized incidents with people with mental illness, and how they have been treated by police, and that have led to inappropriate deaths. So our patients with mental illness are at significant increased risk for something like this. And in fact, you can have patients with mental illness and who are people of color, their risks are even higher. And so some of the problems that we have in our system is how people with mental illness are treated, and it leads to bad outcome. Like this story in Philadelphia was just horrendous, as you know. So the national estimates of this mental health crisis, really about 11 million people, of 11 million people admitted to annually to jails, 2 million have serious mental illness. And so we've known, really ever since, decades ago, with the deinstitutionalization movement, the reduction in state hospital capacity to care for patients, the criminal justice system picked up the slack, we'll say. And so a significant number of individuals with mental illness are now in the criminal justice system. Um, and of course, as the jails have been the de facto mental health system, that increases the risk um, of patients receiving poor care, inappropriate care, and so on. And so, numerous stories about bad outcomes of people with mental illness um, in jails or prisons. And we had one of our state prisons, which is what's called Bridgewater State Hospital, but it was a prison. Um, they had to completely reform it because there were several deaths of the people with mental illness put in isolation without appropriate treatment and so on.
Dave,
Yes,
if I remember correctly, wasn't Bridgewater the place where, what's his name, Frederick Wiseman did his famous documentary, Titicut Follies?
yes, that's correct.
And that was like a real catalyst for reform because it displayed the conditions that were present at the time.
Right, that's absolutely correct. Exactly. And that's right in my backyard too. So it was pretty horrifying to uh, to uh, to hear about all that has taken place. And certainly when I've had patients who were committed a crime and were sent there, they disappeared, like never to be heard from again. So wasn't a great place. But I'm told that things are much better.
Well, the New York equivalent probably was Willowbrook, when which was the Institution for Developmentally Disabled. But at any point, that's a historical digression.
Right, right, exactly. Okay. Let me just see. Okay, all right. So let me just move this over. Okay, of course there's a number of factors that are driving this crisis, and we're going to get into this with some of the programs we have in Boston. But disproportionately high rates of arrest, limited access to healthcare, a low utilization of evidence-based practices, longer stays in jail, high recidivism rates, and more criminogenic risk factors. And I do want to point out that. This mental health system that we have, we all know that it's broken, it's inadequate, it's poorly funded, but we and in fact our goals are to get people well, but the system, the system is set up in a way that really works against us. For instance, first thing is that if you're on government assistance, um, you're put in a position of poverty, and as everyone knows, and I've certainly have witnesses in developing countries, which in extreme cases, but poverty is lousy. Poverty is stressful. It's a daily stress, and as a result, poverty can lead to behaviors, some survival or whatever, that put people at risk for being arrested. But again, the system places people in that position and keeps them there. If they start to work, they say, "Oh, we're going to take money from you," so it's really difficult. And being in a state of chronic stress is not great if you have mental illness. If you're, regardless of what your primary psychiatric diagnosis is, you put chronic stress on top of it, it's really difficult to have great outcomes. So the system itself um, works against what our objectives are, which is to get people well. Let's see. Okay. Now, and then so like detaining low risk defendants, even for just a few days, is strongly correlated with high rates of new criminal activity, both during the pretrial period and years after case disposition. Low risk defendants have a 40% higher chance of committing new crime before trial when held 2 to 3 days compared to those held 1 day or less, and 51% higher chance of committing a new crime in the next 2 years when held 8 to 14 days compared to 1 day or less. And so the system itself also increases the risk for individuals to have more exposure to the criminal justice system. So, and it's very similar to, like when we think about, and I'm going to talk a little bit about this later, but when we think about engagement in our health system, and we recognize that when a person comes through our emergency room and they're put in restraints, it's going to be difficult for them to want to engage in our health system. And so we have to think about what we do to individuals, and how does that impact their lives down the road. Very, very important. Other challenges like law enforcement's lacking alternatives to arrest and options for crisis behavior responses. Behavioral health service capacity is scarce and may not necessarily align with what works to help reduce recidivism. The courts lack diversion options and information to inform pretrial release, and probation approaches are not always effective for people who have mental illnesses. And so, this is just data from Massachusetts and the U.S. And we can see that this is Massachusetts, and this is the U.S. average, and then this is Suffolk County, which is the area around Boston, so it's Greater Boston area, and you can see the rates of jail population are much higher in this area. And of course, this is the area where there are largely, predominantly communities of color. And so not surprising that you would see that. And then, of course, the data is very clear that Blacks, in particular, and then Latinos, higher rates. It's Native Americans even, and significantly higher rates of incarceration versus the white populations. And so we have a problem within our criminal justice system, and it's the general population, but it also impacts our patients with mental illness as well. And this is just some data from Massachusetts, again looking at the jail population. For the males, 31% were open mental health cases, 7% had serious mental illness, and 22% were on psychotropic medication. If you look at females, those numbers are even higher. 79% were open mental health cases, 12% had serious mental illness, and 55% were on psychotropic medication. So again, in our jail system, people with mental illness are at a fairly high rate, which is tragic. So when I moved over to DBU and Boston Medical Center, I was delighted to hear that our hospital ran what's called the Boston Emergency Services Team, the BEST team. And this is a mobile unit that covers Boston and the region, the greater Boston area, and then down as far south as Cape Cod. Um, and we have mobile units, and they go out and to go to people's homes, or we go to the emergency rooms and that sort of stuff. So this was the crisis unit program. So I was delighted to hear that this program was run by our hospital. And my first question to the group was, okay, show me the data. Like what, send me the papers that have been written on this and let me see the data and so on. And everybody looked at me like I was a little crazy. And maybe I was a little crazy. But in truth is they had at that time 15 years of data that they actually never looked at. Now, over the course of another couple of years, I finally worked through all the legal and political systems in order to turn that clinical record into a research database. And I'll show you a little bit of data from that in a moment. But because in particular, like we need to look at the data to answer questions like what are we making the best decisions? Are we getting to the best outcomes for individuals based on our decisions? And as I quickly discovered, hospitalization rates differed dramatically depending on, we had 3 major emergency rooms that we utilized, and the hospitalization rates differed dramatically between those 3 emergency rooms. So we really had to start to look at the data. But then I also realized that there were other components that were already taking place, but they weren't really connected, including our work with the police system, the Boston Police, our work with the courts, and so on. And so we started to really pull this together and to get everyone to work together. We had really good partnerships already established, but they were all in isolation. And the notion that we needed the police and the courts and the emergency services teams, and we needed the hospitals, we needed the community programs, we needed everybody all working together in order to bring about change. And so just in this past year, in 2020, I had an aha moment that we really needed to create a center that focused on pulling everyone together. So I'm going to describe some of the things now. So the BEST program, it's an emergency services program. It's a 24/7. Its goal mission is to respond to people in the community who exhibit signs of mental illness, reduce emergency department overcrowding and waits. And it's also designed to reduce arrest rates, but we'll get there. So experts in emergency psychiatric evaluation and linkage to treatment. It's a call center, and it's been utilizing telehealth for the last 20 years. Excuse me. With that, it also has crisis units, and so that we could prevent hospitalization. Open units, patients voluntarily agree to go to those units, and they get back on their medications and then get connected to care. And the 2 partners emergency departments were at Boston Medical Center and Mass General Hospital, and then the third was at Cambridge Health Alliance, because it's we have BEST and CEST, and CEST is Cambridge Emergency Services Team. And so we looked at the adult data, and over that 15-year period, about 54,000 individuals with 37% being white, 19% being African American, and 16.1% being Hispanic and Latino. 52%, 53% were male. Now, being a schizophrenia guy, I was thinking, schizophrenia is going to be the most common reason for the utilization of the services. It turns out it was mood disorders, representing about 63%. Substance use, about 38%. Schizophrenia was about 18.6%. And so, and many people had multiple psychiatric diagnoses, of course, as well. And so, just looking at, the first question is, what predicted people reusing the services? And it's interesting that you see where if you look at race and ethnicity, so Black and Hispanic were somewhat protective of reutilization of the services at 30 days or 90 days. Certainly, you can imagine this to be the case. Like for instance, schizophrenia, increased risk of utilizing the services at 30 days and 90 days. Same thing with the mood disorders. Some of the other disorders were slightly increased, but less. And if you look at more longer term, going out a year, we still see that being Black or Hispanic is somewhat protective of utilizing the services over the next year. Now, this is when I mentioned that, when you look at data in isolation, sometimes you say, oh, wow, that's fantastic. So is this like reverse disparities or something where being Black or Hispanic is actually protective? And so I said to the group, well, so let's take a subgroup of these folks where we can get access to our health plan data. Because Boston Medical Center has its own health plan, and a good percentage of our patients are in the health plan. And then so we started to look at our health plan data and realized that Black and Hispanic patients have a lower rate of engagement. So they have this experience, this emergency experience, and then they disappear. They stop utilizing services, even at the hospital, the outpatient clinics, the day program, all of those things. So they underutilize all of these other services. And so we have to, take a step back and try to understand why that is. And we're just in the process of doing that. But we do know, like when they come to the emergency room, they're really sick, but then they're not utilizing services after that acute episode. And so we, the data is very dramatic in the lack of utilization, and it's across mental health, it's across substance use treatment as well. And so if we look at this data just standalone, we would be, oh wow, this is great. But the fact is that we really need to connect all of the data points to better understand and follow people through their life to better understand their utilization, their outcomes, and it may be that in certain circumstances that the reason the engagement is low because they're in jail. And so we have to try to figure out, how to do that. So the traditional police response, they usually refer a person to EMS for transport to emergency department. Sometimes when they encounter someone, they require the person with mental illness to move along with no attempt to address the person's underlying behavioral health issues, or they arrest the individuals. In 2010, we started a program with the Boston Police we started collaborating to develop a ride-along program, for instance. And so, so mentally ill individuals causing concern in community at high acuity, they would provide Section 12s to one of the emergency rooms. Community intervention at site with officer at the scene, and follow-up intervention at request of an officer. And so there's, so the best team was started to assist the Boston Police in some of these situations where there were individuals with mental health issues that where the police were called. Detainees having psychiatric crises in holding cells, we were able to de-escalate and do safety assessment, and then get them transferred to the emergency rooms for evaluations, as well as get consultations with forensic psychologists. In 2019, there were 6,900 EDP2 calls, which is emotionally disturbed persons. So EDP2 calls are your EMS and Boston Police. So the emergency services and the Boston Police both respond. In the EDP3 calls, there was just the EMS response. And so there was a significant a number of cases where there was the Boston Police were assisted in responding to their calls. So Boston Police also respond to many other types of calls that involve mental health or substance use, including family trouble, domestic and general disturbances, investigate a person and general affray. And so we continually increased the number, our involvement with the police in these ride-along programs, but there were some gaps in what we could do, and we could only service a few precincts, and I think that I think kind of limited our impact. But we did receive a grant also with the Department of Mental Health for the jail diversion program, and that supported a few areas of within Boston. So we started working with the courts, and we were working with the police at the same time. And then we had response algorithms and so on. But the goal was really to get people the care that they needed, when they needed it, and where they needed it. It would prevent them from being arrested and entering the criminal justice system, which was absolutely critical. And it also worked with patients who they were in the criminal justice systems to lead to better outcomes, get them out of the system, get them connected to mental health care, and so on. And so the clinicians, from the mobile unit had options, with patients. And then we established urgent care centers for drop-in to reduce patients going to the emergency rooms, but also really to kind of supplement their outpatient care, or if they've dropped out of care, and so on. So it's another critical piece to the system. Now, we had quite the experience of working with the police, and work by Michael Compton really highlights the fact that it's better to work with the police who volunteer to participate versus mandating every police officer should do this and so on. And so we developed relationships with a number of police in the precincts, and many of whom became champions of such a program, which is absolutely critical. And so in 2010, we had police referred 25 individuals. In 2020, police referred, there were 401 interventions, where ambulance and ED services were avoided. 10 people were seen in holding cells while in police custody. And police referred or sought consultation on 236 people through the best, our regular best call line. Plus an additional 563 were referred by contacting best jail diversion clinicians directly. And so the program grew substantially, but still it was limited to really just 3 precincts. And so we knew that things needed to change. Look at some other outcomes. 34% of the co-response involved 911 calls where criminal behavior was reported. Of those 192, only 27% of the individuals were charged with a crime. And so our clinicians were able to intervene and move it from the criminal justice system to the mental health system. When arrest could not be avoided, the person in mental health crisis facing criminal charges could often, through collaboration between officer, the supervisor, and the co-response clinician, be summoned to court rather than arrested. Summons provides an opportunity for the co-response clinician to facilitate further evaluation and treatment at the point of contact in lieu of arrest. So really trying to improve the outcomes. Now, part of the program also involves training of police officers, both within the precincts that we were working with but also throughout the system and surrounding communities. And so we trained a lot of individuals, and this to me represented an area of opportunity. Particularly what was happening in the country and highlighting the not only the deaths, but just in general, the police and the treatment of people of color. And I think, everyone I've talked to, person of color, can cite some type of unusual interaction. And I've had several, and certainly in my lifetime with police. But I thought, well, here's an opportunity to kind of change what we do and how we do it, and kind of revamp the training to bring in not just the education about mental illness, but also the kind of the multicultural training that I think is helpful, or that could be helpful to change attitudes and behaviors of police, because that's what we really need to get to, that social justice. It's a critical thing. And I felt, wow, we have an opportunity to do this. We're well positioned. We've had strong partnerships for a decade or more that we can leverage to work with the city of Boston to start to bring about substantial change. And so we started to develop working groups that brought everybody together, including the police, the court system, our emergency services, the school system, people from the mayor's office, and we got everybody in the room, and we started talking about what we can do to better understand what's happening and to lead to improvements. And while this was happening, the mayor of Boston called for police reform, and has, although he has just been nominated to be, I think, Secretary of the Interior by Joe Biden. Right before that nomination, he launched his police reform plan. In that, one of the things that we will do is they increased our budget our budget was about $250K a year for the ride-along. They increased it to, added an additional $2 million, and it should be $2 million annually, so that we could dramatically increase the the ride-along clinicians cover every precinct for a substantial part of the day, as well as really start to connect all of the systems. And so it was really a tremendous opportunity and timely. And, and with that, you know, even further emphasized to me that we really need to not just continue what we were doing, but we need to change what we were doing in order to lead to better outcomes. And so, as you know that there are four key measures we want to look at: reduce the number of people who have mental illness booked into jails, shorten the length of stay in jails, increase the connection to treatment for people with mental illness, and then reduce recidivism rates for people who have mental illness. And I think there's a fifth component that the Council on Government Justice didn't consider, but it's around the racial and social justice that needs to take place. And so I felt that we actually had an opportunity to do that. And so we leveraged all of the programs that we had, the emergency services program, which is about a $17 million a year operation, the police co-responder program, the mental health diversion initiative, which led to a $5 million grant with the Boston Municipal Court system to establish a outpatient assisted treatment program, which does not exist in Massachusetts. And so we have all of this together, and then what we've done is to add our experts from our Center for Multicultural Mental Health, which is a group of psychologists and a couple of psychiatrists. They've been in operation for about 45 years. I think they run one of the oldest multicultural psychology internships in the country. There were many before that, but most of them have gone away. But they do a tremendous amount of training on race and ethnicity and biases and you know all of those factors that would lead one to that could help one kind of make that transition to treating people in equitable ways. Now it's one would think that the police would be rather resistant to something like this, because what we're talking about is a longitudinal engagement, not a implicit bias training, 3-hour implicit bias training. We're talking about a longitudinal engagement in training and working with our personnel and so on. And so surprisingly, we've met little resistance from the police about this piece, because they, over the years, they had reached out to our multicultural mental health group when there was a big thing that happened and so on. But those engagements, it's a one-off sort of thing, not sustainable and not necessarily impactful. And so we're talking about throughout our engagement at all of these points, we would include this multicultural focus as well, to bring about change. Now, of course, this only works if we have access to data. And so now it's a huge task, but now we have access. We've got the best data. We've got the health plan data. We'll do all claims Medicaid data to get all of our patients. We have access to the police data, so they'll now start to share their data. We already had our ride-along clinicians' data, but then we didn't have access to the police's data in their reports. So we'll get those. We have access now to all of the court data. and the probation officer data as well. And so it's a huge task, but we're in the process of bringing all of these different data sources together so that we really can follow people through the systems as they go through the systems and so on. And if the engagement in the health system seems low, but we see that they're in jail, then we understand why, and so on. And so we're really excited about this. We believe that this is going to help us not only answer a lot of questions, but also develop better programs and deliver better interventions. So we're just launching this effort. And so thinking about all of this, at the end of the day, we really want to get to health equity for our patients, health and mental health equity. Um, and it's just a reminder that it's just not about the hospital. And so our hospital really has to think about what they do and how they do it, and they have to think about themselves in different ways. Um, it's not just simply patient comes in, we treat patient, patient leaves, sort of thing. Um, we are undergoing a kind of a hospital reset of their strategic plans, and remarkably, and to their credit, because the data at the hospital showed that 70% of our patients had a mental health or substance use problem. Um, and I always joked with the CEO of the hospital, Kate Walsh, that really we should be a psychiatric hospital with a few medical specialties, because taking care of, as a safety net hospital, taking care of a community with primarily lower economic status, a community of immigrants. Um, there's significant issues that are unrelated to our hospital, but that are impacting on patients' health. And so we have to think about this in a broader way. So the hospital strategic reset, the first phase is on mental health and substance use, which is unusual. Usually your hospitals will start with like surgery or some of the big ticket services that generate a lot of revenue. Here, they chose to start with the system that loses a lot of money, simply because the reimbursements are continue to be so low. And so I think that we have also established a center for health equity, a hospital-wide center, um, to really start to look at our own data and look at health equity differences. A bunch have been identified. For instance, I kind of led the way in having them prioritize the use of restraints, and how there's a difference between Black and brown individuals and white individuals who come through the emergency room and the use of restraints. and as we started diving into it, the data held up, and in fact, there are multiple reasons for that, but that means that there's also multiple interventions in order to fix it as well. So the hospital is undergoing a significant overhaul, and with a huge focus on equity, and it's pretty exciting to be a part of, as well. And so I'm going to stop here. I know this is kind of you jumped around a little bit, but and I also recognize that And I would love to hear how New York has responded to some of these issues. And I know, for years there's been this huge efforts to expand access in New York. And I know that there was a ton of training on psychological first aid and a whole bunch of stuff that's taken place. So you guys are probably way ahead of us. So I would love to hear your thoughts and information about where New York stands in this. So thank you very much.
Thank you so much, Dr. Henderson, for that really terrific and really illuminating talk. I will first turn it over to Dr. Lieberman to see if he has any comments or questions.
Thanks, Jonathan. Thanks, David. Let me start up. So if people have questions, type them into the Q&A box. So just click on the icon at the bottom that says Q&A and post your question, and we'll take those. Let me start off by asking David, in terms of the police as kind of the first responder to mental health crises, to what degree do you think legislation is a barrier? Particularly with the issue of right to refuse treatment, and whether how you can introduce services into individuals that either have had bad experiences and don't seek them, or are lacking sort of awareness of the need for mental health care for symptoms that they may experience as their reality, as opposed to symptoms of a condition that could be helped.
Yeah, that's a complicated question. I think that the one thing that is important, that there's the ride along program is really a partnership. And so I think our clinicians are trained in de-escalation, but they're also trained in negotiations. And so some people may, in fact, who are engaged, they may refuse to accept going to the hospital or that sort of thing. But their alternative is to be arrested in many cases. And so often with that in mind, people are more likely to choose that path versus the other. Now, of course, with every state's laws are very different, and then our outpatient assisted treatment grant, and the reason it's a grant and it's a project is because we don't have any laws for outpatient assisted treatment, court-ordered outpatient assisted treatment. And so we got the grant in order to pilot this, and perhaps this will we'll have the data to support that this is effective. And I don't know what it's like in New York and what the challenges are, and perhaps someone can talk a bit about that. But it certainly is complicated, and we're often consulting our legal team to make sure that we're doing the right thing and following the right rules and stuff. So.
Just one follow-up question, then I'll let Jonathan moderate the questions that are coming in. When you talk about the attrition rate following emergency services and follow-up, a big factor in terms of determining the feasibility of people being able to make connections and continue to be engaged in aftercare is the instability of their overall housing situation, residential, the lack of residential facilities.
Right.
Is there anything that you're seeing or doing that is trying to address that?
Yeah, that's a great point. Both housing and food insecurity have a huge impact in our patient population. So one thing that we're with the housing, one of our emergency medicine docs, who's a VP of the hospital, her name is Thea James, and she received maybe a few years ago, she received some kind of corporate responsibility money, $5 million. Some company was building in Boston, or several companies, and they have a requirement to give back something to, for the community and stuff. And so the state or the city pooled it together into one fund and put her in charge of it. And then she connected with venture capitalists, and she took that $5 million plus their investments, and they bought up a building, a large building, abandoned building in Boston. And they turned that building into affordable housing units. On the ground floor, they put a supermarket in, and that supermarket would use local products and produce at low cost. Individuals who lived in the building would work at the supermarket. They could work elsewhere as well, of course. And we delivered healthcare in the building, health and mental health care. So we had a a floor where we have clinicians going, so on. And so she got people off the street, got them jobs, got them food, make sure they had access to food. And then we partnered with the school systems, some pilot schools, to improve education for the children. And now they're, it was very successful. And now they're on their second and third building. And so, how many lives did that help? It's not clear, but we need to do more of this, and we need to be thinking in this way. If you don't solve the housing, like we know, like homelessness is a high driver of medical expenditure in our hospital. It's a high driver of emergency room visits. And even in the data I showed you, homelessness was a predictor of coming back in 30 days, 60 days, 1 year, and so on. So we have to be thinking about these other factors that have a significant impact on people's health and ability to even engage in the health system. And so it's economics, it's food insecurity. Like I'm fortunate that I can write a prescription and send my patient down to the food bank, and they can get food for the week. And I can write what type of diet they want, diabetic diet or and that sort of stuff. And so we have I think there's gardens on the rooftops of just about every building in the hospital that the community helps maintain and stuff. And so we're doing it, but we need to be doing more of these sort of things, because again, if you can't address the housing, then it just keeps going.
So we have a question from Prudence Fisher, who writes, fascinating talk, discouraged by how people with mental illness are often treated by the police. I wondered how you actually got the data and could track people across different systems. For example, were there problems in terms of confidentiality, de-identifying data, etc.?
Yeah, we've had lots of lawyers, and it's taken quite some time, but we worked with each agency and organization, like the school system, the police, the courts, and so on. We have data sharing agreements. That the data will be connected, it'll be de-identified, but of course there are some variables that are needed to connect the different databases and that sort of stuff. But we went through it, with the state and all of the entities that were responsible. But it took quite a process.
Great. Okay. The next question is from Jay Gingrich, who asks, any thoughts about what characteristics make some police officers open to versus resistant to your programs to identify and divert EDPs to mental health care rather than the justice system?
Yeah, that's a great question. And what I didn't mention in our, as we've established our program evaluation system, part of that will be evaluating the police themselves. And surprisingly, they were also open to that. So we don't know, at least from our experience. It's clearly, we can, you can, like anecdotally, like there's certainly some people who have family members with mental illness, and so they were much more open to engaging with this. They're, maybe even themselves have had some experience with like depression, anxiety, or so on. As you know, many police are also former military people. And so they certainly have had some experiences themselves or with their colleagues as well. So what I'm very interested in that question is like what not only what allows police to want to be involved with this program and engage, but I'm more interested in like what are those factors that predict or suggest that they're ready for change. Now, that being said, we've encountered numerous police that refuse to be involved whatsoever. And so that with our clinicians available, they get a call that's clearly one of our calls, and they refuse to have that. And so I want to study them too, to see what that's like. Now, the one thing that we in changing, as we expanded our system with the ride along, we also change a critical point or component of the system is that we now have a clinician sitting with the 911 dispatcher. So the people who receive the 911 calls, like a clinician can pop on that call, and so we can better target which calls our clinicians go out with. But before, they were assigned to one police officer for that day, and they would do whatever that police officer did. And so maybe 20% of the time they were actually doing meaningful work. So we've actually changed that too. But this is, I think, it is an important area to study. But even as we've taken this further, what are those factors that would predict someone would be willing to be trained by a multicultural team and it leading to meaningful changes, like the openness, because they've already had like mandated trainings, right? And then all over the country they've had mandated trainings on kind of multicultural stuff, or what cultural all whatever the buzzwords were, social, all of that stuff, but with little impact. So we have to also in our process, we have to get to be able to predict who's going to benefit from this and so on.
Thank you for that. The next question is from Ezra Susser, who asks, what are your thoughts about using vacant hotels and apartments during the pandemic to accommodate homeless people with mental disorders, and advocating to keep these for that purpose afterwards?
Yeah, that's a great question. I think that what's amazing was that there was a tremendous response during the first phase of the pandemic to care for the homeless and to get them off the streets and housing and that sort of stuff. And it was a, really a good example of what can be done. And, the utilizations of hotels, like our city, they opened up the convention centers and so on. And so these weren't COVID positive people. They were just providing beds for people and getting them off the streets and stuff. And so I think that we've had discussions with our governor about this. But I think this is purely, it's down to finances and it's down to vision. And there's something that we are pushing, because if you can take away that factor in people's lives, and then give them opportunities and resources and so on, you can really make a difference. So again, it's what's happening in New York. Does anyone know how is New York responding to this?
There were a couple of comments addressing that, and I'll dig those up and read those to you. But while I do that, there was a question from Ralph Wharton that I wanted to ask. He asked if you can compare Massachusetts to other states where you have familiarity.
Can I compare other states to Massachusetts? And as far as what?
Massachusetts is always, sort of in the lead in terms of progressive initiatives. And this is sort of an example of it. Is there data to indicate whether programs exist, similar programs in other states, or whether the data that show the effectiveness of this are comparable to what can be gleaned from other states' programs or lack of programs of this sort?
Yeah, I mean, there's a lot of every state has different initiatives and so on. I don't get pick like the ride along programs. I even heard one state has decided to hire, I think, social workers and psychologists as police. So they made a decision that's how they're going to address this. So I think every state has different approaches. I don't know of, but I'm sure there are, like kind of the comprehensive approach that laid out. I'm sure there are other examples, but I'm not aware of any at this time.
So Ezra Susser notes that New York is on the tipping point in terms of using hotels, etc., and he is happy to comment. So maybe Simon, if you're able to bring Ezra Susser into the panel, he can speak to that. And then Linda Rosenberg noted that New York City has designated several precincts where mental health staff, not police, will respond to psychiatric emergencies. Let me see here. Sally Sattel writes, great work. How do you handle drug use by residents on the premises? Actually, maybe now that Dr. Susser is on, maybe we will let him comment, and then we can come back to Dr. Sattel's question.
Hi, that was a great talk. Thank you. To keep it brief, New York has used vacant hotels to a large extent. There's thousands of people, I think it's more than 10,000 now. And it was paid for by FEMA because the hotels were going to go bankrupt. So it helped everybody, in that sense. But the problem was that it was initiated originally as a very short-term policy. They thought the pandemic would only last 2 months or something, and they were going to turn them all out afterward. But of course, that hasn't been possible. So they're now, in a sense, squatting in these hotels, which are much better living conditions. They have their own rooms usually and so forth. And there's quite a building advocacy movement to maintain this and expand it, because it's the only immediate response, to the growing homelessness. You need long-term supportive housing. It takes a long time. And so it's being actively discussed by the mayoral candidates. And I can, honestly, my view is it's a once in a lifetime opportunity to address homelessness, because, you know, it's been 40 years. It seems intractable. Here's a chance to actually make a big dent in it. And it's in everybody's interest. So that's just, maybe I'll leave it at that for the moment.
Well, Ezra, isn't this basically like a back to the future? In other words, remember the old single room occupancy hotels that used to exist that went away? Is this recreating those at a slightly higher, more expensive level?
No, because in the sense that they're hotels, but they're being moved into some very fancy hotels, actually. There's a whole variety. The single room occupancies were very run down. They had shared bathrooms for a whole floor. They just weren't adequate living situations, but they were better than being homeless. And one reason that homelessness emerged in such large numbers is they converted them into fancy hotels, the single room occupancies. So it isn't back to the future. It's, you could say it's back to what could have been a much better future. So.
Yeah. Thank you, Ezra. Appreciate it.
Okay.
So, yeah, thank you so much, Dr. Sasser. A couple other questions for you, Dr. Henderson. One is from Dr. Sally Satel, who says, great work. How do you handle drug use by residents on your premises?
How do drug use by residents?
Yes.
You mean our trainees or our, no, I'm kidding. I'm kidding. Well, here's the other piece to this is because substance use is such a huge issue. We have, you know, we work with several organizations that are really on our campus and right by the hospital. And we have a very large addictions program. Much of it is focused on opioids. That's where all the funding has gone in recent years. They just got like a $90 million grant to roll some stuff out around the state. We have multiple programs, treatment programs available, and including we do have a safe use room where we have medical monitoring, and so people can come in and use in that room, and we have a nurse, and their vital signs are monitored while they're there. So it gets them off the street and gets them instead of shooting up and then falling into traffic, and that sort of stuff, and so we're in the process. The hospital has been a harm reduction addiction approach mostly because it's been mostly they have a large addiction medicine workforce, and addiction psychiatry was very small or not very much engaged, and we've expanded that, so we're now at the point where we're expanding other treatment programs that are not just harm reduction. And we're bringing this to, for instance, that housing facility, so that people can engage in therapy, that addiction focused therapy as well. But we, I think that we also in the hospital, addiction can be treated in any department. So which I think is also very helpful. So wherever the patient engages, whatever department the patient engages our health system, they can receive addiction treatment. So that's also very helpful. And today, we had to, people were shooting up in our bathrooms at the hospital. So there, a bunch of things have had to be implemented. But we know that people are going to use it, and our goal is to try to get them ready to stop using, replacement and stuff.
Thank you. There are a bunch of comments written in just expressing how much people appreciate your talk and are inspired by your work. I think our last question is from Cristiane Duarte, who asks whether the mental health effects of the housing intervention are being assessed or measured.
I'm sorry, the mental health effects of
Housing, is that, are you assessing?
Yeah. Yes, exactly. Yeah, there's a pretty extensive evaluation component. And we're looking at a bunch of health outcomes as well.
Jonathan, let me just also comment on a question by Akhil Shenoy, which was, what about the risk of danger through aggressive behavior of patients? We recently had one of our residents, assaulted, and in some cases it's an occupational hazard, but in the context of the services that you're providing, it seems that it's even more of a risk than in a typical ambulatory care center. Has this been an issue that has been frequent, or is there training in terms of how to reduce the potential for aggressive behavior and injury to caregivers?
Yeah, absolutely. Everybody gets trained regularly on this. Number one, I think that we, in the different components, in psychiatry, of course, that risk exists. We recognize that, and I don't think that we've had a high incidence of assaults or attempted assaults. I think within each system, for instance, like if one of our clinicians is going to go to the home, there's usually with like either the police or sometimes with the EMS if we know the patient well. So and in other settings, I think that it hasn't been a huge problem. But of course, it also we recognize and we're trying to fix one thing and then this impacts something else. So we're also trying to reduce the use of restraints, and that's one issue that comes up readily. And this is why I commented that there's a clear racial and ethnic difference in the utilization of restraints. So we know we use restraints to keep the patient safe, to keep staff safe. And that's perfectly appropriate in some instances, but oftentimes people, security is called before any clinician evaluates the patient, and because the patient has mouthed off or something, or complaining about the services, or the wait's too long, that sort of stuff, and security is called and patients put in restraints because they're deemed to be threatening, and they actually were just Black or Hispanic or something. So we're trying to address those types of occurrences, while also, of course, trying to keep everyone safe. So, but we're constantly thinking about safety in all of the stuff that we do.
So I will turn it over to Dr. Lieberman for final comments in a second, but just two quick things. One is I just wanted to thank you again, Dr. Henderson, for spending time with us and talking with us about your really terrific work. And also I wanted to let everyone know that next week's Grand Round speaker will be Nabila El-Bassel, who will be talking about her work with the HEAL initiative. So I hope everyone can attend. And with that, I'll turn it over to Dr. Lieberman.
Dave, thank you for really a great, really interesting and important presentation. We missed the psychopharm research, but you also expanded your work to address probably more consequential problems in terms of how to provide services. So keep up the good work, and we'll look forward to seeing what the results of this innovative program is when you can come back with some data which shows you its effects. And also, the other thing is that this is scalable. So even though it's a local ground up program. Hopefully it'll be able to be disseminated to other municipalities, and it would be nice to see it expanded on not just a individual statewide or locality-wide basis, but on a national basis.
Great, great. Well, thank you very much. I enjoyed being with you today. I appreciate it.
Okay. Well, be well, stay safe, and thanks again, and we look forward to seeing you in the future.
Take care. Bye-bye.